Okay, good afternoon. I'm Young-Guk from Severance Hospital. It's my great pleasure to have a chance to interview the world-renowned vascular experts in this session. So Dr. Lawrence Garcia is co-moderator, and we have great experts, Dr. John Robert Laird, and Dr. Chae, and Dr. Aloke. Good afternoon. So we have seen that endovascular therapy has shown excellent outcomes in different vascular areas, from aorta to iliac, femoral popliteal, and BTK regions. So I think there has been significant improvement of EVT outcomes due to the improved skills and the devices. However, we have still a lot of challenges to overcome. So I think we'd like to exchange our thoughts on on the current status and the future perspective of EVT in the aorta and peripheral intervention in this session. So my first question to Dr. Laird. So you presented your experience over 30 years in the field of peripheral artery intervention. So what do you think? You have already talked about the all changes in your talk, but what have changed in the management of PAD over the last 30 years, and what remains to be changed in the future?
Well, there's a lot to talk about. We could probably spend the whole hour just on that question alone. During my talk today, we didn't talk about medical therapy for patients with peripheral artery disease, and that's probably the most important thing we need to do for these patients. And thankfully, there have been some significant improvements in the medical care of these patients. We've realized the importance of smoking cessation, and we are more actively involved in treating patients with medications to try and get them to quit smoking. We have better antiplatelet agents, antithrombotic therapy, in particular, the exciting new approach with low-dose factor Xa inhibition, more aggressive use of high-intensity statin therapy, and new alternatives like PCSK9 inhibitors. And some of the other innovative therapies, I think, are what's maybe the most important change in terms of management of PAD patients. But in terms of our interventions, I think we've continued to make iterative improvements in the iliac arteries with better stents, covered stents, better self-expanding stents, better ways to treat across chronic total occlusions. So our interventions have resulted in better outcomes in the iliac arteries clearly over time. We've made some progress in the femoral popliteal segment due in large part to anti-restenotic therapies. Drug-coated balloons have made a big impact in the SFA and popliteal arteries. Drug-eluting stents have made an impact. And so our outcomes have gotten better, from the groin to the knee. I think where we've made the least amount of progress is below the knee. We're a lot more aggressive. We treat vessels more aggressively. We do bidirectional approaches. We get across CTOs using advanced techniques. But we do not have durable therapies below the knee. Balloon angioplasty itself is not a very durable approach. Drug-coated balloons so far have not been shown to be effective below the knee. Bioresorbable stents have not yet been proven out. And we have limited data with balloon expandable coronary drug-eluting stents which show effectiveness, but a more recent trial with a self-expanding drug-eluting stent, the Saval trial, was negative. So we still have a lot to figure out below the knee in terms of improving outcomes for BTK interventions in our CLI patient population. So a very long-winded answer to your question, but hopefully we covered a lot there.
Well, I think that was great. On that, the good, the bad, or the indifferent, Dr. Finn, do you think that the drug-eluting devices, which have shown some, obviously, as John just said, that, they've shown benefit, do you think that there still is going to be this uncertainty between the Limus drugs and the Taxol-driven drugs? How do we get around all this? Do you think we're eventually going to have to go head-to-head and see where they best fit? Because I'm sure that there's going to be benefit in one group versus another. and then not all one will win for everything
Yeah.
type of thing. What are your thoughts for the drug-eluting technologies?
I think we're really at a crossroads in terms of the amount of new technologies that are coming out now. Obviously, we've had paclitaxel-coated balloons now for a while. There's pretty good data surrounding those in terms of their efficacy. There are concerns about safety still somewhat. There's concerns about emboli, some mortality issues, I think, which have been mostly attenuated by the subsequent analysis that have been done. But I do think that Limus would be a better alternative. It's certainly a better tolerated drug. It remains to be seen whether the technologies are as effective as the paclitaxel-coated technologies, in the sense that the drug-coated balloons we have that are Limus drug-coated balloons, I think the issue is how good is the anti-restenotic benefit? How good is the drug transfer? How permanent and sustained is it? And will that lead to really sustained long-term results? That remains to be seen. We have small trials. We don't have large trials. And eventually, we may need to do a trial head-to-head against paclitaxel-coated products, just because I think, it's no guarantee that Limus is going to be better than paclitaxel, just because the technology required to transfer the drug is more complicated.
Yeah, Dr. Laird already, mentioned that there has been not much progress in the treatment of below the knee lesion. So, Dr. Chae, so what do you think is, so the reason for this difficulty
Yes.
to treat the BTK lesions?
Yes, through this conference, we think about a lot about the below the knee lesions, especially in the previous session. Dr. Finn talk about the above knee and below the knee. The lesion characteristics is very different, and then one of the difficult lesion is the below the knee lesion is anatomically, it's usually a long segment and usually heavily calcified and usually the total occlusion. So that's why the below the knee intervention is very difficult. But recently, the new techniques, including the bilateral approach, retrograde approaches, something, so we can salvage the limb. Is that fortunate and very good news for the patient. But there's no, Dr. Laird mentioned about there's no the solid, the durable therapies possible. So that's why it's very difficult. But I think we need the more the sophisticated treatment for the below the knee is needed, and also the most important thing is medical treatment for the patient.
If we just pick up on that, I think that, Aloke, you had spoken a bit about the risk of distal embolization with DCBs, particularly with the Taxol derivatives. Do you think that, John has said in the 30 years, we have the best medical therapy at the time was, whether it's aspirin alone, and the treatment options were really angioplasty.
You're right.
And we're at a point now with the below the knee stuff where it's just angioplasty that's winning. And I guess there's two parts to this. One is, do you think the Taxol derivatives with distal embolization, is that really going to be a big deal? And I guess that's number one, kind of where we are with interventional stuff. But I guess ultimately my question for the below knee, back to Dr. Chae, is that I wonder if the heterogeneity of this patient population for below knee is so great that we still don't have that kind of really laser-focused randomized trial in our future mids. You understand?
Yeah.
I just don't know if that's going to ever happen for us.
Right.
What do you think?
Well, I think you're right about there's no question we've shown that paclitaxel-coated balloons, and I don't want to generalize because I think each technology is different and they have different embolic potentials. So each different balloon is made of different excipients and coating and may have its own, and different drug loads, and all those influence the amount of emboli that are produced. But I think that these emboli the significance of the emboli should not be understated, in the sense that I think some of these we test these balloons for safety in normal animals. They have good flow. They're healthy. They're going to tolerate this. They're going to clear it, and they're going to regenerate skeletal muscle because skeletal muscle does regenerate. But I think that in these patients with PAD, it's not the same. And you probably know better than me. These people have slow flow, impaired already. They have marginal function, and I think that embolic debris there tends to stay there and sit there, and I think that becomes an issue for them. They're much less tolerant of emboli, and whether we speak about the heart or we speak about the lower extremities, people that have sick vasculature are much less tolerant of these type of issues. So I think that we really do have to be very careful about making products that we think are safe, as well as efficacious. And when you use two, you may not just use one balloon. When you use 2, 3 balloons, those emboli just triple, double, depending on the number of balloons you have used. So I think it's very important for interventionalists to understand that and to know that there are limitations to the technology currently. It may not be ready for another below-the-knee trial right now. I know the Limus drugs balloons are, getting approved for those, but I don't know what's going to happen in terms of outcomes.
Right. So let's move to different vascular areas. So I would like to ask Dr. Laird, according to the recent long-term clinical follow-up of the randomized trials, EVAR appears to be inferior to open repair. So how can we improve the outcome of the EVAR? What do you think about that?
Well, that's another tough question you asked me. So I think you outlined the issues very well in your presentation today. The late follow-up from a number of randomized trials and other trials seems to indicate higher aneurysm-related mortality in patients treated with EVAR compared to those treated with open surgery. In EVAR 1, after 8 years, the mortality rates are going up for the EVAR patients relative to the open patients. And in the DREAM trial, late follow-up, there's a much greater need for additional interventions in the EVAR patient population than the open surgical patient population. I think it's important to keep in mind that most of the patients treated in these trials are treated with kind of the first and second generation EVAR devices, particular Anurex, Talent, first generation excluder, devices that probably not as effective as the more advanced endovascular stent grafts. And we are seeing better data in some of the longer term trials with other more advanced EVAR devices, such as the Endurant graft, where we now have 10-year follow-up from the ENGAGE registry showing really excellent outcomes with freedom from aneurysm-related mortality in 94.7% of patients at 10 years. So part of the problem is that the studies we're talking about are evaluating some of the earlier devices. We now have better devices. But we need to continue to iterate to improve devices. We need probably to have better fenestrated devices and branch graft devices so we can seal more proximally in a healthier segment of the aorta than we currently do. I don't honestly think that chimney grafts and snorkel grafts are the long-term answer. We need better fenestrated grafts to solve the problem. And using technologies such as endo anchors to try and prevent late graft migration and also prevent dilatation of the aortic neck, which is a significant component of the problem, I think will also help in the long term. So being more creative with use of technologies like that, I think will continue to improve our EVAR outcomes over time.
Thank you.
So, Dr. Chae, you had a great presentation with, a thoracic aneurysm this morning. And do you think that, how can we make that safer? There's a lot of big vessels that come off of your arch, and very important things to not cover. And then as you go further distal, as was the discussion today about covering the spinal arteries.
Yes.
I guess two parts to this. One is, how can we make that a safer procedure? Kind of like what John was just talking about for AAAs. And then secondly, do you think that TEAVR will ever become a generalist's intervention as opposed to a real big specialist in a bigger sense?
Yes, that's very important because the age as the expectancy is longer and longer. The big vessel problem, the instances will increase. But in the thoracic aortic aneurysm, it is very heterogeneous in terms of the etiology, and also the anatomy is very difficult, and because it is closely related to the cerebral event. And also, if we are treating the thoracic aortic aneurysm, it can make a spinal ischemia, so it's very fatal. So that's the reason why the treatment of the thoracic aortic aneurysm is very difficult. And we did have only 10 years of data about the TEAVR and the thoracic aortic aneurysm. So I think we need more clinical data, and we need more sophisticated treatment modality to treat the thoracic aortic aneurysm. So I think, so the most important thing is we have to share the decision making with the surgeon. So that's the most important thing, I think.
Yeah, I think the challenge with the TEAVRs, zone 0 is kind of that holy grail, right? If you could ever get down that far without really messing up either the great vessels or the coronaries is really one of those things that may never happen, but it's one of those things that, unlike an EVAR where it's going to be a fenestrated graft you can probably plan, these are usually more acute cases, which make it so much more difficult in that respect. Listen, I think that every one of these presentations has just been phenomenal, and I think what we've proven is that we still have a long way to go when it comes to both iterative change, developments, and then the patients that we treat and how we treat them. And hopefully, as time goes on, we can show, one, that we not only do it well, right, at the time, but we have a very durable outcome that has as great an outcome as an open procedure, but more likely a more durable outcome with less morbidity, less mortality, and we can help our patients live longer and happier lives with whatever we're doing, whether it's in the chest, the belly, or the lower legs. So with that, I want to thank the panel and TCTAP for a great opportunity to come and speak at Seoul one more time. So thank you.